Good afternoon, and welcome to the NorthShore Outcomes Research Seminar and the 7th of our COVID-19 Research Series webinars. Today, Dr. Deborah Stolberg, Dr. Amy Whitaker, and Lee Hasselbacher will be joining us to present their team's research on the rapid innovation and adaptation in contraceptive care using telemedicine study. We will also be joined by an expert panel, including Dr. Whitaker from the University of Chicago, Dr. Terry Ann Thompson from IBIS Reproductive Health in Cambridge, Massachusetts, and Dr. Emily White Van Gompel from NorthShore University Health System. Next slide. I'd like to give a special thanks to our first responders and to all who are working on the front lines during this pandemic. I'd like to thank the program directors and the Director of Outcomes Research, Dr. Bernard Ewigman, and NorthShore University Health System for this support. I'd like to also introduce myself. I'm Sean David. I'm a Program Director for Translational Science in the Outcomes Research Network. And Rachel Brewington, who is our Administrative Assistant, who is navigating this webinar with me. So the NorthShore Outcomes Research Network was started in late 2018, was structured with key academic leadership across our institution, and it provides support to catalyze research across NorthShore, as well as our CTSA partners in the region. And the goals of the ORN are to enable uniform community access to care that is effective, efficient, and equitable, to enrich the practice of medicine, and to support key strategic, clinical, quality, and operational decision-making. The objectives of this seminar series are really to encourage the flourishing of principal investigators, to create a network of collaborators, disseminate our research activities and resources to investigators, and to promote a culture of collaboration and team science. Bridging of researchers to their peer communities as well across Chicagoland. And we want to deliver outcomes research that demonstrates improved patient population health outcomes and health equity for our communities.
Thank you, Dr. David, and hello, everyone. In today's webinar, all attendees will be muted with the exception of our panelists and speakers. However, there will be some opportunity for interaction. If you have any questions or comments at any point during the presentation or the Incubator Hub discussion, please submit your communication by using the chat function as noted by the blue arrow on the screen. If you are on a computer, you can access this icon by hovering your mouse over the bottom of your Zoom screen. Please give special attention to the audience of your message before you submit it. As you can see on the image to the right, you can choose to message either the panelists and speakers. This will include myself, or you can choose to message everyone on the webinar. Feel free to leave your questions and comments at any point during the presentation. If you are experiencing any technical difficulties, please let me know by messaging all panelists, and I will assist you as best I can. I'm going to hand it back to Dr. David, who will go over the agenda for the day.
Thank you very much, Rachel. So the agenda for today, we're starting off now with an introduction. And following that, we'll have the lecture from Drs. Stolberg, Whitaker, and Hasselbacher. We also, during this lecture, strongly encourage you to, if you think of questions, to submit those in the chat. We'll collect those throughout the time of the lecture. But we'll also, starting at 3:40, have a question and answer session. And so definitely once that starts, please submit your questions, and we'll do our best to make sure that we cover all the questions during the seminar. Following that, we'll have our Incubator Hub expert panel discussion with our panelists, Dr. Whitaker, Thompson, White Van Gompel. We'll also welcome all the presenters to participate in that panel discussion, where we're going to cover discussion questions having to do with health equity, with clinical dissemination, as well as policy and future translational science implications. And then we'll have some closing remarks, during which we'll ask you to fill in an evaluation of the seminar and direct you also to a link which will allow you to show a video of the seminar in case you or your colleagues have missed it. It's on a standing YouTube website. Next slide. Good. Our speakers today all hail from the University of Chicago. We have Dr. Deborah Stolberg, who is Associate Professor and Chair of the Department of Family Medicine at the University of Chicago. Dr. Amy Whitaker, who is the Chief Medical Officer of Planned Parenthood of Illinois and a Clinical Associate Professor of Obstetrics and Gynecology at the University of Chicago. and Lee Hasselbacher, who is a senior policy researcher with CI3 at the University of Chicago. And without further ado, I'd like to introduce Dr. Amy Whitaker, who's going to start off the presentation today.
All right, thank you very much. Excited to get the presentation started. Rachel, we can go to the next slide where I'll give you an overview of the presentation. We're talking about these 5 points. So I'm going to give a little introduction about family planning services in Illinois before and during COVID-19. We'll talk about the state response to COVID-19 and the motivation for this study, for the REACT study. Then we'll move on to get more specific about the study, the qualitative and quantitative part of the study, some of our findings from the qualitative part of the study, and implications and next steps, both clinically and for research. Next slide. So in Illinois, there's a diverse array of providers who offer contraceptive services, including federally qualified health centers, private physician offices, teaching clinics, et cetera. And in this study, we did look at other family planning providers across the state, although the primary focus was on Planned Parenthood of Illinois, and that is my area of expertise. So I'm going to focus now on Planned Parenthood of Illinois' services before the pandemic. And we see a lot of patients for sexual and reproductive health services. We provide healthcare services from STD testing to gender-affirming hormone therapy, and of course, contraception and abortion. As you can see from this slide, we have 17 health centers all over the state, primarily in northern and central Illinois. And we see about 7,000 unique patients per year. In the Chicago area, where we have most of our health centers, although maybe about half actually, we are one of many providers of sexual and reproductive health care, but in central Illinois, we're really often the only provider of some of our services. And so I'll move on to focus on some of our contraceptive services. Next slide, please. And specifically, not just our contraceptive services in general, but how our provision evolved during the COVID pandemic. So both before, during, and we're not after yet, but we'll after as well. We provide every FDA approved method of contraception. At Planned Parenthood of Illinois, we have sliding fee and even options for free birth control for patients who can't afford it. And during COVID, we did evolve to provide our methods in a new way. And I think evolve is a lovely word. It involves a slow, steady progress where each step you think about it. But in fact, it looked a lot more like this. Next slide. We made a lot of changes in a short amount of time in the spring of 2020. And every one of us felt like Chris Farley looks in this picture. Next slide. So starting in March of 2020, our biggest step was we consolidated our footprint from those 17 health centers to 6 health centers and temporarily limited services to services that weren't time sensitive and that didn't require an in-person visit. And we called these essential, but in fact, the stay-at-home order that was issued by our governor basically said that all reproductive health care was deemed essential. So unlike some other states where some of our colleagues had to fight to stay open and keep providing services, we really had the ability to provide whatever services we wanted and felt like were safe to provide. So as we contracted our brick and mortar presence, we also sought ways to expand access while keeping our staff and patients safe. So on here are a few things we did, a few of the 1,000 things we did. We implemented self-instruction for self-injection of Depo-Provera. We extended prescriptions beyond 1 year after brief telephone consultation rather than having come in for the annual exam. We instituted no-touch supply visits, which let patients pick up birth control without having face-to-face contact with staff, to name a few. Next slide. But really, one of the absolute most exciting things we did to accelerate our implementation of telehealth services. So there are 3 components to our telehealth services listed here in this slide. PP Direct is actually something that we had been doing before COVID for about a year, maybe to 2 years. It's a non-synchronous app-based telemedicine option that doesn't have face-to-face video contact. It had been, we offer it for pills, patch, and ring. And then we had just started recently before COVID offering UTI treatment. But during COVID, we increased our call center's ability to refer patients to that platform and tried to get as many people onto that platform as possible. And we went from about 200 visits per month to 700. And then in August, we also started allowing patients to get emergency contraception. But the drawbacks I've already mentioned, it's non-synchronous, it doesn't have video contact, and most importantly, we're actually not able to take insurance via PP Directs. So it's all self-pay, and therefore not the best option for all of our patients. Telephone care, I already mentioned, we extended prescriptions. Basically, early on in the pandemic, we just spent a ton of time making emergency protocols that would just allow as much care as possible to just be over the phone. And this, we basically provided free care over the phone, extending prescriptions, treating STDs with known contacts. And we extended the prescriptions, actually. The conversations were so funny. We're like, oh, we're probably okay extending it just a month, but let's extend it for 3 months, just in case this whole thing isn't over in a couple months. A year later, we're still doing it. But obviously, it's a short-term fix. And so our really kind of pie in the sky goal was to be able to offer synchronous, real-time, face-to-face, video-based healthcare. And this is something that we've been planning for several years, but licensing for the technology was slow. Priority within the organization was not highest, and figuring out the logistics was really hard. So this was moving along, but not all that quickly. And then when COVID came along, magically, the licensing got easy. Suddenly there were codes and you could bill for it. And then obviously within the organization, our priority rocketed. And so by April of 2020, we launched this program. So from mid-March to the end of April, we did what I am 100% sure would have taken us a year or longer before COVID. So it's one of the things I call a COVID silver lining, just how quickly we were able to get our telehealth up and running. So next slide. And so you can see back in April, we had 129 visits. It's continued to grow since then. Just this past January, we had 369 visits. We are still working on growing it more, marketing it, just making sure patients are aware of it, and also sort of fine tuning the processes by which people can participate in it. And I'm really glad that we're able to participate in the research project, so the process and insights that we learned in this pandemic can have a wider impact. And so with that, I'm going to hand it over to Lee Hasselbacher, who is going to talk about the project itself. Next slide.
Thank you, Dr. Whitaker. And yeah, so given all of the changes in access as a result of the pandemic that Dr. Whitaker was just talking about, we were interested early on in understanding how family planning care was adapting and how providers and patients were experiencing access to care. We sought to interview providers and explore their perspectives on changes in service delivery, patient access and quality of care, the key interventions they adopted during the pandemic, and any potential for long-term impact in any of the lessons learned from this process. Okay, next slide, please. And we also wanted to understand the trends by looking directly at service delivery and patient satisfaction data. So that's another component of this study that we've been looking at. We'll be looking for changes in access to contraceptive care as reflected in the total volume of patients served, and time from patient appointment request till their actual appointment date. We're also interested in analyzing data collected to evaluate patient satisfaction and describe any shifts in the choice of contraceptive methods that patients received. Next slide, please. Oop, I'm sorry, go back one. Sorry, very next one. So in order to explore these research questions, we have two parts of our study. So one is involved conducting interviews with family planning providers. And this research has been conducted in two phases. The first phase has been interviewing that has been conducted during July and September of 2020. And we sought out family planning providers working in a range of settings and in a variety of specialty backgrounds. So this second phase of interviews is actually underway right now and began in January and involves interviews with clinicians, clinical support staff, and administrative or billing staff who've been involved with telemedicine services, specifically at Planned Parenthood of Illinois. So speaking to what Dr. Whitaker talked about. So we had one phase that was looking earlier on in the pandemic in sort of a wide range of providers. And then the second phase has been focusing specifically on Planned Parenthood. And just to note that in this presentation, we've been using telemedicine and telehealth interchangeably, in part because our interview participants also sort of talked about them interchangeably in the interviews. And then the second part of our study actually involves the collection of patient chart data and patient satisfaction data and analysis. And this data collection is ongoing, and so we'll not be presenting any findings from that data today. So we'll be focusing mostly on the interviews. Now you can go to the next slide, sorry. And here you go. This will offer some description of our characteristics of our two interval samples. So we have one from Planned Parenthood, where you can see we've got a range of sites within Chicago and without, in a range of types of providers. So we're interested in hearing from clinicians about how the actual visits are going, but also hearing from clinical support staff or admin and billing about some of the back end issues. So how the implementation is rolled out with the tech platforms, for example, or how they've handled telehealth billing and administration. And in our non-Planned Parenthood sample, you can see we reached out to a number of providers across the state in different types of settings, and then with different specialty backgrounds. So both OB-GYN backgrounds, but also family medicine and pediatrician backgrounds as well. Okay, I can go to the next slide then. So now I'll share with you a couple of the themes that we've seen emerging from our early analysis. And then Dr. Stolberg will take over and describe some additional themes, as well as some lessons learned and implications for our research going forward. And most of this discussion around themes focuses on the provider's use of telemedicine specifically for contraceptive visits, which was by far the most common innovation adopted during the pandemic, and the one that became the large focus of our interviews. So the first thing we saw in our preliminary data analysis was that overall providers have liked using telemedicine for contraceptive services. They've appreciated the access to care for patients, especially early on when some clinics were closed. And for patients who are seeking prescriptions or refills of their prescriptions, or just counseling on contraceptive options. Providers have also appreciated on a personal level that some of them were able to work from home early on. And nearly all providers have felt that using telemedicine to provide contraception has been feasible and manageable. And that has even come from some of those clinicians who had little training or familiarity, or had to roll out their process very quickly at their own clinics with little infrastructure or support. And you can go on to the next slide. This is a quote actually from one of our clinicians, where they talk about they actually feel like they have more time to talk to their patients. They feel less rushed, and they feel like they have a better chance to answer all of their patients' questions through telehealth. And they thought that that was actually a big improvement in their care. And interesting, the same provider who's a clinician at Planned Parenthood talked about sort of the access for patients too. So she had a quote about one of her patients was actually like combing her child's hair while she was talking about her birth control. And she thought that that was actually great for the patient to be able to multitask in that way. Even it might be a little challenging for the patient, but she thought that was actually something that allowed the patient to get care when they might be otherwise too busy. Okay, next slide, please. The next theme we'll talk about is around some of the challenges that we heard about in some of our interviews. One of them was definitely sort of the initial rollout. As Dr. Whitaker noted, it happened so fast, and especially for those clinics and settings that had no plans to introduce telemedicine, I think there was really a challenge. And so the providers had to quickly adapt to using platforms that they and their patients were not familiar with, or had to adjust to new platforms as things changed over time. And so it meant that they were switching maybe even to phone visits and trying to make those work in ways that they hadn't before. And as Dr. Whitaker noted, Planned Parenthood did have some advantage that they were already planning for telehealth services, telemedicine services. So the folks that we talked to from Planned Parenthood did say that it was helpful to have been thinking about it already. They felt that the training was a little bit more, that there was training, that there was leadership around this in the ways that some of our other clinicians noted that they were sort of left to scramble to pull together services, especially earlier on in the pandemic. And in particular, providers talked about insertions and removals of long-acting reversible contraceptives, such as intrauterine devices and contraceptive implants, pose particular challenges. So these are methods that can only be supplied in person. And some clinics had closed early on, so patients were, either diverted to the open clinics with less appointment availability, perhaps, or guided towards a different method that they could get in the interim before they could come into their to get their longer-acting method. And recognizing some of these difficulties, some sites talked about that they made an effort to prioritize the in-person visits for those patients who did want LARC insertions or removals to make sure that they would have continued access. And interestingly, there were a couple providers who talked about this need to streamline services and provide as much care via telemedicine as possible, prompted them to eliminate a requirement for some post-insertion visits. So going in to check on strings for IUDs, for example. And many providers already had eliminated that requirement and found that it wasn't necessary for patients. So in some ways, this actually prompted some practice changes that maybe made access easier for some patients, and that they didn't have to come back for that visit. And next slide, please. And continuing with some of the challenges that were found, some providers also reported that challenges existed for patients and continue to exist for patients accessing the technology platforms. I think partly, again, at the beginning, there were many different platforms being used. So patients who saw multiple providers were maybe being asked to create accounts and log into different platforms. And that there was just a need to kind of troubleshoot with patients, and maybe some of that burden fell to medical assistants or RAs who were seeing patients before they were able to see the provider. So they had to sort of navigate some of the technology ahead of time. Providers also noted that, in some cases it was harder for them to ensure a provider-patient relationship, some continuity around that relationship. So giving the example of, providing contraception counseling over the phone to a patient, but then that patient would come in and see a different provider if they were coming into the office for follow-up care. And, along the same lines, the providers talked about that, discontinuity, but then, would also mention that the convenience of being able to do those appointments was still so great for patients that, maybe that was a trade-off that patients were willing to make. And then finally, I think as Dr. Whitaker alluded to too, some patients didn't seem to be aware of the telemedicine options. So I think it was only unless they called and asked for an appointment or asked to be seen that they were maybe directed to a telemedicine option. And I'm sure, again, that was, a function of everybody just trying to manage services at the outset. But I think, creating more outreach going forward is a way that a lot of clinics are thinking about how to address that challenge. And with that, I'll turn it over to Dr. Stelberg to continue.
Great, thank you. Make sure that, okay. So the next theme that emerged was how telemedicine impacted different groups of patients differently. Interviewees talked about how telemedicine improved access for patients living in rural areas and others who had barriers to physically coming into clinic. This was especially true for patients wanting prescription methods of contraception, such as the pill, patch, or ring, where we may really not need any elements of physical exam in order to provide those services. For prescription methods that contain estrogen, there is a contraindication for patients who have uncontrolled hypertension. And so we noticed some variation in how providers applied the need for this one element of physical exam, if you will, whether the patient had to come in somewhere to check their blood pressure or self-report their blood pressure. We heard a range of practices. Next, some interviewees mentioned that telehealth at times was difficult for patients when the provider and patient did not speak the same language. This was in part because interpretation services were not all integrated within the tech platforms. And providers also wish that more of their documents that they share with the patients were uploaded into their database so that they could be shared electronically and specifically uploaded in multiple languages. For adolescents and other patients who might really specifically have privacy and confidentiality concerns, interviewees talked about both positive and negative effects. Some had examples of telehealth being more private than in-person care, while for others, telehealth posed a challenge to confidentiality. One example of the way telemedicine can improve privacy was described by a family physician at an FQHC. So we asked all interviewees about whether telemedicine increased or decreased the stigma that can be associated with reproductive health care, and this physician responded as follows. So next slide. I think telemedicine has positively affected in the sense that I think it's reduced stigma because, as I said, people can, place a call from the privacy of their bedroom and let you know what they like, right? And then we can move forward. So it kind of gives them a chance to be a little more anonymous or protected. They can choose to do a phone only, an audio only visit. Next slide. In a similar vein, some providers mentioned the potential for telemedicine, especially with audio-only phone visits, to reduce biases that providers may have based on a patient's appearance. But seeing into a patient's home with video was also described as a potential aggravator of bias. Perhaps relatedly, two sub-themes suggested low-income patients might be less able to benefit from telemedicine. First, some providers noted that when a patient is getting their birth control on site because the clinic receives public funding, such as Title X, to dispense low or no cost methods directly to patients, these patients have to come into clinic. As far as we could tell, clinics had not come up with ways, for example, to mail pills or patches directly to patients. Although, as Dr. Whitaker mentioned, Planned Parenthood did create a no-touch pickup option. Second, some providers observed that more of their telemedicine visits seem to be with white and higher income patients. We're not sure if this is an accurate perception or why it would be, but one provider offered a hypothesis. So next slide. What I can tell you is that I feel like I probably see the patients that have a lower socioeconomic status more likely in person than over telehealth. And my best guess is that those patients are already out, for example. I have patients that work at pizza places and things like that. And so I think that those patients are already out and being used to, being in public spaces. So they're not as wary of actually visiting the practice. And to the earlier point about providers' biases from patient appearance, one midwife described a specific concern. So next slide. A lot of people providing contraceptive care may still approach it with a kind of paternalistic attitude in which they think they know what is best for the patient and may kind of steer or try to steer the patient towards the method or methods that they think is better for this person. Even if the person has said, I'm leaning towards X or I really want Y, I think that visual component, that physical assessment, how we read the patient looking at them, as well as how the things they say, I think that kind of plays into our overall assessment, whether that's fair or not. Next slide. Finally, our last theme is the myriad lessons and suggestions that interviewees shared about telemedicine for contraceptive care. First, it put access to care as the central issue in a way that providers saw as a lesson for our health system overall. As this family physician described, it's made care very accessible to people without having to physically bring them into the clinic. And especially it's highlighted a lot of the things that don't really require a physical visit. And especially something like contraception, it's impacted it because when we're having those visits, a lot of the times we're not doing much of a physical exam anyway. It's more of a conversation and a counseling session. Next slide. Other lessons were about how to sustain and improve the service. For sustainability, providers talked, of course, about the importance of reimbursement parity, both between in-person and telemedicine care, and also between different ways of having telehealth visits. They said this not just for their own revenue, but to be flexible in responding to what patients want. As we heard above, video is not better for all patients, but some payers privilege video over phone visits. One family physician described, I think if we were getting reimbursed appropriately for phone visits through a lot of the insurance companies, I think it'd be a lot easier, especially for people who don't have video or don't have video on their phone or laptop. And so that makes it very difficult for them if they can't do phone visits. Next slide. Finally, providers want to see more effort to raise patient awareness so that patients can fully choose between different options for how to receive contraceptive care. Some care requires a clinic visit, as Lee mentioned, for a LARC insertion or removal, for example. But if you don't know about telemedicine, you may think that the only option is to come to clinic, even if that wouldn't really be your preference. And some patients may even forego care because coming into clinic is difficult for them. One administrator at Planned Parenthood observed, we need to do more marketing and research to find out how folks who are not taking advantage of it might be more interested in taking advantage of it and make it more accessible to a wider population. Okay, next slide. So as I wrap up our findings, this is a good place to acknowledge the inherent limitations of this kind of study. With a qualitative sample of 37 individuals, the study does not represent all perspectives in the state. We did have less representation from outside Chicago and from non-clinicians than we had hoped. We do still have the opportunity to recruit and complete another handful of interviews, so we hope to achieve better balance. But in thinking about what these interviews tell us for the future of telemedicine, I want to highlight that family planning providers are addressing many of the same challenges and opportunities that all clinicians are, such as reimbursement concerns and patients having access to technology. But they're also tackling issues that I would argue family planning providers have often led the field in, such as how to value patient preference in clinical decisions, how to really prioritize confidentiality, and working on challenging our own biases as providers. If we can succeed in carrying these values into the space of telemedicine, family planning will be a model for so much else that we want to do as healthcare adapts to new circumstances. And the final implication is that our care delivery does not exist in a vacuum. In Illinois, for example, we were fortunate to have reproductive health care declared essential from the start of the pandemic. We also already have state policies that support patient access to contraception. For example, Illinois Medicaid covers birth control prescriptions written for a full year. A patient does not have to go back to the pharmacy repeatedly if she doesn't want to. We also have coverage for advanced provision of emergency contraception, meaning I can write that script for my patient to get the EC before it's an emergency. Will we, both in our state and nationwide, see ongoing policies with telemedicine that assure contraceptive care is accessible and patient-centered? I think contraceptive care is the perfect opportunity to advance the value of telemedicine and vice versa. We need to be flexible to meet the patient where they're at, to continue to work at prioritizing patient-provider communication, and be vigilant that we're implementing new services equitably. And that brings me to our final question, which is what comes next? So next slide. As Lee mentioned, next up for us for our study is a quantitative analysis of Planned Parenthood of Illinois data, and that will include a primary outcome of time to appointment from when the patient first made their contact, when they had their appointment, and we'll be examining that from the time period before the pandemic through the launch of telemedicine and into the pandemic. And then our other outcomes for that quantitative analysis will be the mix of contraceptive methods that patients are using and patient satisfaction. Beyond our study, we think the research also raises questions that should be addressed in future studies. So first is the provider perception that more affluent and white patients are using telehealth disproportionately accurate. If so, why, and is this a problem? And lastly, how do we best integrate high tech and high touch? Is there an inherent trade-off between patient convenience and patient-provider relationship? And how do we bring the optimal balance between these to each encounter? So next slide. Just want to pause to thank both the Society of Family Planning Research Fund that funded the Planned Parenthood component of this study, and also to thank the remainder of the study team members. And then you can go to the final slide. Oh, Rachel, you're still muted.
Thank you very much. Thank you, Dr. Stolberg, Dr. Whitaker, and Lee for shedding some much needed light on the contraceptive space during COVID. At this time, we can take a few questions from our listeners. As stated earlier, please input any questions in the chat box by addressing it to all panelists and attendees so everyone can be involved. If all questions are not addressed, please feel free to contact Dr. Stolberg at her email shown on the screen. Okay, let's see. So we have a question. Do you have plans to do interviews with patients, especially those who did not engage in telemedicine?
We have some patient interview study related to family planning care, but it's based on the funding a little more focused on abortion cares and specifically medication abortion, which can be done through telemedicine. We don't currently have plans to interview patients specifically seeking contraceptive care, but we would be interested in the future.
Okay. Next question. Did you find that patients from religious hospital systems who did not have contraceptive access found telehealth to be a way to overcome this barrier?
Lee, you want to hop in on that one?
Sure. Yeah, I'm trying to think if we saw that come up in our interviews for this study, and I don't recall any providers actually speaking about that specifically, but I could imagine that this would actually be a great way for patients to be able to access services, especially if they're bound by geography or insurance, that maybe some of the expansions about insurance coverage. Again, it wouldn't necessarily help you if you're going out of network, but it would help you if you're going further geographically than you would have otherwise been able to do. So yeah, it wasn't something that specifically our providers talked about, but I don't know, maybe Dr. Whitaker has some examples from in the clinic, but I think it's a great question and a great opportunity, I think, to take advantage of making sure that patients are aware of this service, especially if they're bound by geography. If they're in a rural area that only has, say, for example, Catholic health centers, they could be taking advantage of the service.
Yeah, anecdotally, we definitely see a lot of patients at Planned Parenthood who maybe normally get their the rest of their reproductive care, obstetric and gynae care from a Catholic-based institution. They end up coming to us for their contraceptive care. And that's not uncommon at all. And then we also see patients whose insurance is through a Catholic-based place where again, contraception wouldn't be covered. And so we end up seeing those patients as well. And so I don't have numbers, it's purely anecdotal, but it's definitely something that happens all the time.
And I can just add that specifically for this study, because we wanted to hear people's experiences providing contraceptive care, one of the eligibility criteria for the providers was that they're currently providing contraceptive care. So if they did work in such a restrictive setting that they weren't allowed to provide contraception, they wouldn't have been eligible for the study.
Another question. I'm curious, in your interviews with providers from non-PPIL clinics that did not already have telemedicine queued up, What were some of the challenges they raised? And more specifically, did funding from infrastructural changes get raised?
Yeah, I can take a first pass at that one. I think, from the providers who were, they were often from like sort of a range of settings. So some were in academic environments, some were in private clinics, some were in community health centers. So I think that all, the setting that they were in contributed to how much of an infrastructure there was for ramping up telemedicine services and what kinds of platforms they were able to use. So I think there was sort of a range. Some folks from some of the more established settings were able to kind of work together with their bigger teams at maybe their hospital or in their academic setting and come up with protocols. But I think some, the ones that stuck out to me the most were the ones from like private clinics or community health centers, where there was a bit more of like just a quick scramble to try to figure out what will work best and how to, is it going to be DocsMe? Is it going to be, all these different platforms that kind of emerged as possibilities. And then, again, some of the providers really had no training or like internal support. It was just sort of like, all right, go, try your best, try to get, work through it. And again, even those providers still ended up with a pretty positive view of telemedicine overall, especially in the circumstances of the, early days of the pandemic, when they felt like patients weren't going to come in otherwise, or that their clinics were actually closed temporarily. So yeah, I mean, there was definitely, just the challenge of like transitioning the service along with everything else that was going on, at the time, providers in their own lives having to adjust to different circumstances. So yeah, it was funding didn't come up specifically as an issue, but I think it was partly in these non-Planned Parenthood clinics that were early on. It wasn't even so much a matter of funding. It was just figuring out the logistics of how is this going to work? How is this flow going to happen? So I remember some providers talking about like even things like figuring out the actual workflow. Like, is Tuesday going to be all telehealth day? Or are we going to try to mix telehealth visits in with in-person visits? And then like, how do you juggle that? And how do the providers bounce between doing the telemedicine visits and the in-person? Just figuring out the workflow in the clinic was something else that we probed a bit. And so, yeah, answers your question.
And I'd just like to add that even though we had some things queued up at PPIL, like those type of questions, that logistic, where is it going to be? How much are we going to offer it? Who's going to do it? How's it going to fit into everything else we do? We had not even begun to think about before COVID. I don't even think we knew we were going to have to think about it. So.
I have another question, by the way. Excellent presentation, and you should be really proud of this great work that you've all done across the state. With React 2, with the quantitative analyses, are you going to be able to tell whether the reach of contraceptive care actually paradoxically increased during the pandemic because of this? And if so, for whom? Were some groups, affluent groups, more likely to take advantage of it, and some of those barriers? And if you've already explained that, apologies, but I'm really curious to know how you're gonna.
Yeah, it's a great question. We will be looking at geography, so patient zip code and distance to the nearest Planned Parenthood health center based on zip code, and including with our amazing biostatistics team, potentially trying to look at whether that changed over time with different events. Specifically, as Amy mentioned, some Planned Parenthood clinics temporarily closed. So did people whose closest health center was one that closed. Like, how well did telemedicine close that gap that you might have anticipated would cause a delay because of their geography? So yeah, we will be looking at that question.
Thank you.
We have another question. Given the comment from one provider about paternalism and prescribing tendencies, did anyone comment on prioritizing prescribing, initiating contraception, and deprioritizing LARC removal or deprescribing?
We asked really specifically. It was a concern of ours as well that providers might have a bias that I'll just say, like, who should be getting pregnant right now. So if what someone is calling for is she wants her IUD removed, that can wait, that was going to be a bias. And I have to say across the board, and Lee, correct me if I'm wrong, but people really said that specifically with regard to LARC methods that require that in-person visit to both insert and remove, that insertion and removal visits were equally prioritized. So we were really pleased to hear that result. But I'm interested in if my co-presenters would say differently.
Yeah, I would agree. I think there were, a couple comments where folks were, kind of sort of reflecting on like, how are people even getting together right now early on in the pandemic? But I think that was more so just to, reflect on like, how is care changing and how are people thinking about accessing care differently? But yeah, I would say in general, when we're thinking about access to LARC methods, there was, an understanding that we should prioritize the visits in person for those patients who need to come in and have either that offered as care to them or if they want to remove their device.
These are great questions, everyone. If anyone has any more, please send your comments now. Otherwise, we could begin to transition to the expert panel.
I think I saw a question from Terry Ann. Do you want me to just read it?
Oh, great. Please, yeah.
I'm curious, in your interviews with providers from non-PPIL clinics that did not already have telemedicine queued up, what were some of the challenges that raised, and more specifically you already asked that one, Rachel. I'm sorry.
Okay.
I did just post a new question for you though, Debbie.
All right, thank you.
No worries.
Yeah, so as you mentioned, there are certain groups for which privacy and security during a home visit might be challenging. And often that concern that gets raised with telemedicine is a diminished ability for providers to see signs of interpersonal violence. Did this come up? Lee, do you remember that?
Folks definitely had perspectives on like what it meant to be able to see patients in their home and in their home environments. There wasn't a lot of discussion that I remember from this early analysis about looking specifically for interpersonal violence. There was more thoughtfulness, I think, around sort of what we talked about a little bit with bias, is people reflecting on like, does a video visit in, providing a peek into someone's home offer either more grounds for potential bias as you're making assessments about what method might be best for them, or does it decrease because you're sort of seeing someone in their comfort zone and maybe they're able to talk more freely and maybe they feel more comfortable and in ways that they might not in the clinic. Maybe the power dynamic has been reduced a little bit. Some people reflected on that. That might be a possibility, that it sort of flattened the experience, that you're not going into a clinic, sitting in a waiting room, sitting in the patient, the doctor's office, that you kind of feel a little bit more like it's evened out. So there was a lot of thoughtfulness about like the dynamic between the provider and the patient and what the provider might be thinking about or making assumptions about, but we didn't get into too much discussion about assessing for interpersonal violence in that setting. And I think that's definitely a concern. Like we definitely talked about adolescents and young people and how they might have mixed benefits of, maybe it's good that they can call from their house. They don't have to leave their home, find transportation and get into the clinic. And, that they could be doing accessing this care from their home. But on the flip side, maybe mom's in the next room and then they don't feel as comfortable talking about it, or they're worried that mom's going to come in and listen in. So we talked about the confidentiality piece more in the context of adolescents than interpersonal violence, but I think that is a really important question.
Yeah, that could definitely be something we could sort of add as a probe in our interview guide. We asked about sort of what are the potential losses, what are the downsides, and that could include, relationship, it could include not doing a physical exam. And I think the example that you raised where physically seeing someone might tip you off to a potential concern about violence is an example of a loss with not being able to see someone that we could specifically ask about. It's a great idea.
Yeah, also, related to that, the issue of psychological safety of seeing patients in their homes could maybe differentially affect some people from different backgrounds. And I wonder if that's come up, just having the screen on, seeing people walk around in the background, is that a barrier?
So I'll just add from the, I think that it can be a barrier for some people. And one of the things that I found most interesting about like this study and also the process was how different, I mean, it's a silver lining, right? That we could do it so quickly, but it also meant that we didn't, there were a lot of mistakes made, right? I mean, and so some of them might have been like, ideally you'd have a whole month conversation with patients and providers, of this type before you do it. Like, what is going to be these effects? So this research and hopefully future research will help us sort of fix some of those things, because you'd never, in an ideal world, you would never not let someone come in the clinic, right? But in COVID, we had periods of time where we're like, you can't come in the clinic for this type of visit because we just don't know. I mean, it felt like for 3 months, the world was actually on fire. And now as the embers they're just embers, we can kind of be more reasonable. So yeah, I would just say that moving forward, having these conversations, maybe bringing patients into this type of research is going to be the key to really figuring out these important underlying equity and safety issues with telehealth.
Okay, that is all the time we have for questions right now. Please feel free to insert any additional questions in the chat box for our presenter to review later. I will now hand it over to Dr. David, who will introduce our expert panelists for the Incubator Hub panel discussion.
Thank you very much, Rachel, and to each of the speakers. For our next segment, I would like to introduce our 3 expert panelists who will provide some additional insight into the implications of the research presented. Again, we have Dr. Amy Whitaker, Chief Medical Officer of Planned Parenthood of Illinois, and Clinical Associate Professor of OBGYN at the University of Chicago. We have Dr. Terry Ann Thompson, who is Senior Associate with IBIS Reproductive Health in Cambridge, Massachusetts, and Dr. Emily White Van Gompel, who is a Clinical Assistant Professor at the University of Chicago Pritzker School of Medicine and the Department of Family Medicine and OBGYN at NorthShore University HealthSystem, and a faculty leader in the residency program. So there are 4 discussion questions that we'd like to cover today with respect to this presentation. And the first one is, what are the implications of this research for health equity? This question goes out to all the panelists and the speakers. I think Dr. Thompson was going to start this conversation off. Thank you.
Sure thing. So first of all, let me start by saying thank you to our presenters for sharing this work. I mean, what we know about the evidence on telehealth for contraceptive services is actually limited. And in fact, there is some evidence from a recent scoping review that looked at about, I think, 12 studies that were used to facilitate the use, adherence, and continuation or provision of a contraceptive method. And from those studies, the evidence was quite limited, meaning it was moderate, like a moderate impact in essence of telehealth for contraceptive use. So this is a really welcome addition, and I want to applaud you for actually leading the way and bringing some of this work to the fore. So when I think about research that's been done on telemedicine, what comes to mind is that so far it's really focused on outcomes, it's focused on access, and it's focused on equity as it relates to telehealth or telemedicine versus in-person care. However, this surge in the use of telemedicine for sexual and reproductive health services during COVID has really prompted us to think about whether telemedicine is actually addressing or whether it's exacerbating known barriers to utilization of healthcare services. So what we've learned, I think, from your study actually aligns with some of the emerging evidence, and that evidence is suggesting a few different factors as key predictors of telemedicine use. And those factors are marital status, their age, its geography, race and ethnicity, as well as mental health. Further, in studies that have looked at telemedicine for the use of, or rather its use with medication abortion, what we have seen is that there are some differences in patient preference for face-to-face communication. That those preferences run along the lines of younger patients, patients who are nulliparous, patients who are less educated. And in one study that recently came out from the United Kingdom, what we see is that patients who identified as Black African, or Caribbean were the ones who preferred face-to-face communication. So all of this together, I think, suggests that closer attention really needs to be paid to some of the factors that facilitate the use of telemedicine. And you've mentioned some of those factors here, right? So it's factors like insurance coverage. Health insurance coverage for telehealth is variable, and it varies by both insurance type and by the state of residence. So that could result in variable access to the service. There's language. Love that you mentioned the language piece. Accommodations are not only needed for limited English proficiency, but it's also needed for American Sign Language. And as you correctly interpreted or correctly stated in your presentation, interpreters are missing from many telemedicine programs, right? So better integration is definitely needed. And then there's a whole issue of technology and connectivity. There's research that's shown that only half of low-income households actually had broadband internet service, and less than a quarter of those with internet access actually had smartphones. So there's clearly something here along the lines of the digital divide. And then I would be remiss if I didn't mention that there's also issues related to literacy. So whether that's digital literacy, thinking about the fact that those with low digital literacy will have more difficulty downloading or installing or using unfamiliar sites, or health literacy, right? And the fact that those with low health literacy might actually face substantial difficulties in accurately expressing their health conditions or self-monitoring as is needed with contraception, or even thinking about some of the self-awareness or self-education that might come along with apps, as an example, that are trying to give you information about different contraceptive methods and helping patients to decide which one would actually best meet their needs. So I really want to hone in on this piece about paying closer attention to the factors that facilitate use of telemedicine, because I think that's really where we're going to see some of the inequities, or rather health disparities, arrive as it relates to this healthcare delivery model. And I will pass it along to my other panelists.
Thank you. That was very rich discussion. And Amy, Dr. Whitaker, would you like to comment on health equity implications?
Well, I think Tiran did a beautiful job commenting on them. I do think that when you're providing something and it's like it's a shiny new penny, right? Like everybody wants to put a lot of time and energy into it. And so I think always having this conversation of what are the health equity implications and doing the research to make sure that you're not just running with it with this idea that it may help health equity, and then you get 2 years into it and discover that it is actually worsened existing inequities. And I think that's a real risk with telemedicine. And so again, it's really just being able to get the data like from this research. So I think of it in is moving on also to question number 2, like what are the implications for the research to healthcare dissemination and implementation, is getting research, disseminating this research findings that, hey, this is not something that without any other work is going to improve health equity, right? It may seem like it, like, oh, we're going to help these people who can't come in, whose lives are so busy they can't come into clinic, or who live in rural areas. But when in fact, just implementing it alone is not enough for health equity. You have to look at the impacts. You have to look at who's taking advantage of it. You have to make sure that the way you're doing it has that in mind the whole time, I think is, as important as implementing it at all. So that's what I have to say about it. And that's sometimes, especially at the start of COVID, there wasn't a lot of time for that type of discussion, because everything was on the fly. We all looked like Chris Farley in my slide. We're just like, run away, fix it. How are we going to see patients? But now that we can think and process to really make sure that this intervention is not worsening health equity is going to be an important part of our process.
Yeah, and I'll just jump on. I echo all of that, but I would like to just call attention to the methods used here in this study and hopefully going forward, and how that contributes to exactly the goals that our two panelists just mentioned, which is rather than thinking about the implementation, I think from the way it happened naturally, which is we can't even get our providers able to use this platform. Let's make that our first goal, as opposed to saying, how do we get our patients to be able to use this platform, and how do they want it to happen so that they are most likely to uptake it, and which, what adaptations are needed in which communities. I think this kind of research takes that really important stance of looking at this from first the provider level, but next to the patient level, to see where can we change this new, if you think of telehealth as the intervention, how can we adapt and refine and retest this intervention such that it's going to have the greatest impact on the people who need that impact the most.
If I could just make one addition here too, on so many panels that I've been on telemedicine, I've been trying to challenge us to think about telemedicine not as any different from any other healthcare delivery model, and to really, as we move away from thinking about it as this new innovation and to thinking about it as a regular healthcare delivery model, to really hearken back to so many of the lessons that we've already learned, which is that there are many a thing, including medical racism, that really sort of interferes or disrupts healthcare utilization in this country. And so it should not be there won't be any difference with this healthcare delivery model if we are operating in the same, with the same tenets and operating in the same way. So I really have been challenging folks to not think about telemedicine as different in any way, but to think about it as, for this new healthcare delivery model, how do we use some of these lessons, some of this evidence, some of this data that we've already collected around healthcare utilization, and more specifically, barriers to that, to ensure that we avoid some of those at the outset, right? Like not avoiding them or addressing them later on, but really sort of putting things in place now to ensure that we don't actually end up in the same space as we have with other healthcare delivery models.
Yeah, thank you. I think that implementation science approach that also combines it with community engagement and using the right metrics, all those things are great opportunities for development. But I think this is a big area it's an opportunity to try to do things right, because I think the cement hasn't dried. So, and I think this will inform a lot of that work. Other healthcare dissemination implementation comments from the group?
I do want to just make one point, and I was struck by this comment that Amy made, and I think it really is an important one to move forward. Planned Parenthood has been sort of the leader in when I think about use of telehealth for sexual and reproductive health services, and specifically thinking about abortion and contraception, Planned Parenthood has been a leader in that space. And I think one of the ways in which they have helped to lead that path is because of the engagement in research and the collection of evidence on things like safety, effectiveness, and acceptability of the model, right? And we've seen that in the case of medication abortion, that evidence was really the evidence that enabled them to move it from, the very first Planned Parenthood model, which happened in Iowa for medication abortion, to many other affiliates across the country, in addition to independent abortion providers. And so I really want to sort of stick a pin on this stick a pin in this point of evidence and the ways in which both disseminating it to lay, maybe not lay, but disseminating it outside of academic spaces is really what can drive implementation and drive interest in a model, right? And so thinking again to Planned Parenthood and the ways in which they disseminated that information, it's dissemination through webinars and holding meetings with other providers and affiliates. It's making sure that the information got to them through research briefs or fact sheets, right? And having ambassadors who had implemented telehealth, being sort of almost like peer clinics in some ways. I say this because I do a fair number of collaborations with other affiliates around medication abortion, but it's a model that I think really helps move that research from the paper to the actual actionable work, or makes it more actionable, I guess is the phrase I want to use. And so I do want to stick a pin in this idea of like evidence and how we actually move it into non-academic spaces is really, really important and really key to the adoption of telemedicine and across a variety of spaces, right? Whether that's in medication abortion or if that's in contraception, I think that's really key. And then I think the other piece that I wanted to mention is that telehealth is also really suited when I think about how you move it to like funders or insurance carriers. One of the things that makes the evidence palatable to them is the fact that we have some evidence now around telemedicine or use of telemedicine in this field that looks at the breadth in terms of use, right? So we can show that telecommunication technologies can be used at consent for consenting. It can be used for the procedure itself. It can be used for follow-up, right? Or it can be used for education. Like we can show the breadth of the benefits of that use, as well as the benefits of different modalities. So I think that has really helped when you think about evidence making the case for insurance carriers or making the case for funders to facilitate adoption. I think that evidence, that piece around safety, acceptability, and then also just the benefits writ large, both with how it's implemented as well as what it can do for both patients and providers is really key.
Thank you so much for those comments. And I want to make sure also that the presenters have an opportunity to comment on health equity. If Lee or Debbie would like to share any comments about the implications of health equity.
I have to say, I was surprised that the providers, and it wasn't just one or two, it did seem to be a trend, and you hate to draw too much as far as trend conclusions from qualitative interviews, but that patients of color were less likely to access the care through telemedicine. So I think it raised more questions for me than it answered. And really, is it about marketing? Is it about the digital divide? Or is there something related to trust? Is there something related to not wanting a provider in your bedroom on your phone? I just think the reasons, explanations, and what we should do about it are really huge. So that's sort of where I'm left at this point, is that this opened more questions than it answered.
Yeah. And Lee, did you have any comments on health equity implications?
Yeah, I would echo for what Debbie said. I think it was something that as we started doing these interviews and hearing providers kind of bring up who was using it, who the patient populations they were seeing in the telemedicine visits, definitely made us think about like what are the issues. Again, is it fear of COVID as well. And I think there was definitely pandemic related considerations that, are specific to, especially like when we were conducting some of the interviews, it was really early on, still in the summer. And I think there, are there populations that had more fear of COVID? Are there populations like the one provider we quoted who actually saw patients who were, essential workers? So they were out already in public. So coming into the clinic didn't feel as unknown to them. So yeah, I think that there's a lot to untangle both around the equity issues that Terry Ann brings up. And I think the, untangling some of the pandemic related issues, and maybe they're not, maybe they're very intertwined, like, in terms of access. So.
Thank you. Yeah, so we've had some discussion about implementation, adoption. What do you think are some of the implications for policy, in particular around payment, but also what could we better do as a society to enable this, the reach and the diversity of this telemedicine for contraceptive care?
Is that for all of us at large?
Yeah.
Can I? Okay. I think, for me, what is striking about this is that it, as Debbie and Lee have just vocalized, it raises more questions than answers about how telehealth should be done. And if insurance companies are now saying these are the requirements to get it reimbursed, you have to have a video, there has to be some sort of component that's face-to-face in that way, that then puts up more barriers, and it may be that patients don't find that as acceptable. And so that could worsen inequities or reduce access. And so the way insurance companies and payers in general are going to set those regulations about what counts and what's appropriate, I think can have huge implications for either worsening disparities or reducing disparities.
If I could just tag on, one thing I will say is that it's not just the insurance piece. There's several waivers and shifts in regulations that happened with COVID. And, Amy mentioned that when she talked about Chris Farley, like it took less time because literally the entire universe conspired to make it happen, right? So whether that was Health and Human Services waiving the enforcement of HIPAA for telehealth, whether that was the Drug Enforcement Administration loosening requirements for e-prescribing, it was everybody conspiring to make that remote provision more possible. And so I think one of the things that comes to my mind, Emily, is really thinking about what is driving some of the states that have already started to make some of the changes permanent, right? So we've seen several states already actually who've adopted or made permanent the allowance of telephonic delivery of contraceptive services, right? And there are other states who have not. And so my question is really around, like, what is the evidence that's driving you to do that? Is it the increase that we saw that Amy showed on her slide, moving from 200% to now, Amy, you're at close to 500%, right? Like, or it was some crazy high percent of people that are getting services this way? Is it just the evidence that had already been in existence that was showing that, online platforms appropriately screen individuals for contraceptive services? Or is it like, what is driving some of the states to actually make some of these policies permanent? And how can we nudge the other states, once we find out what that evidence is, nudge them to make these options more available? Because to your point, if telephone is an option, there are some clients who will find that more accessible in terms of the services, and the more options that we can give, I think the better. So just to add that.
You have more faith than I do that states base their policy on evidence.
Yeah, I was going to jump in and be the Debbie Downer on that one too. And I think it's really a shame that this type of research has as little impact on policy as it does, in terms of convincing states that are basically against sexual and reproductive health care, right? There are states that don't want to make any, that may actually move forward with opening the door to telehealth in other arenas that are still going to make contraception difficult and are certainly not going to let us send, medication abortion medications by mail, which as some of you probably know, the Supreme Court just said we can't do that. And so in terms of its effect on policy itself, I'm less optimistic. I do think that the research, if you can show that it provides, I think you're more likely to get push or some sway with insurance companies than you are to get it with state legislators. And again, I hope I'm wrong. I hope you're right. But I think it's unfortunate that evidence doesn't drive policy and politics as much as it drives us.
Well, there is one case, right? I mean, we did see evidence for telemedicine for medication abortion effectively stop one ban, not all of them, but one, right? So I hold on to that always, Amy, that if that evidence can actually effectively stop one ban, that maybe it will happen again. And so we will continue to generate evidence until we can do that. But I agree with you. I think, when I think about the pieces that would seem appealing to a state, whether that's the state thinking about the CMS program or, federal policy, the things that come to mind are whether it is deemed, which is why we focus so much with telemedicine on making the case that it is equal care, right? Like we've made that case a lot. And I think that should be evidence that like prompts a state and or like the federal government around telemedicine, like the use and adoption of it. But the other things that come to mind are things like cost effectiveness and or propensity for providers to use this new model, as well as safety and effectiveness. But if there are other pieces of evidence that come to mind for the other panelists, like I would be so curious to hear what else you think might be interesting for a policymaker or convincing.
Well, we have a physician at NorthShore who was successful in lobbying Springfield, the state government, to have mandatory reporting of dense breast tissue from mammograms, who also was able to have other states also adopted similar laws, and I think also for covering of all breast imaging based on the indication. So there are some examples of people who are good at it. They know how to speak to legislators and present the evidence. So yeah, that might be possible for this area too. So great. The other discussion question I have is, what are the implications for future translational research directions? And we heard one example with React 2. I think that has future, but what are your thoughts, panelists, about where does the science need to go?
For me, it's all about the patient and adapting telehealth to maximally serve the patient in the way that they need to be served. And just as a provider, at a FQHC here in Chicago, I can just say that my own experience has been most patients really don't want to deal with the whole video component, and they just want to talk to me on the phone. And it's frustrating, but at the same time, I think it would be wonderful if we had similar sort of best practices, the way we teach primary care residents to build rapport and, make sure that they're doing certain things during their visit to connect with their patients. So how do we do that with telehealth? And so I would love to see more evidence understanding how do we truly make telehealth patient-centered and delivered in a way that's going to meet the patient's needs maximally.
Thank you. Great comment. Others? Dr. Stolberg.
Oh, it looked like Amy had something to say. Amy, you want to jump in, and then I'm happy to.
No, I was
after
just
you.
going to agree. I think
Right.
one of the first questions was, what about the patients? And I would say that if we could add any voice to the research that we've done, it would be to get the patient perspective.
Yeah, I second that. And I also will always bring a integrating reproductive health services into primary care lens. In a lot of ways, Planned Parenthood is an ideal environment to start this research because some factors were essentially held constant. The rollout happened statewide, the training happened. Not that there wasn't, some natural variation, but I think when you look at then primary care, there's much greater heterogeneity, and what brings patients in, whether that's physically or seeking care in a huge range of settings, electronic, telephonic, in person, et cetera, could be really varied from, their sprained ankle to their diabetes. They're with their baby, but oh, by the way, they haven't been able to get their birth control filled. I mean, there's, just such a huge range of primary care issues that we're dealing with. So how do you make reproductive health care patient-centered in that setting? And how do you train clinicians, provide the support, et cetera, for telemedicine across a huge range of issues? And again, I think we should be learning from Planned Parenthood that does center sexual and reproductive health in a patient-centered way, and then do that, but do that in a setting where we're, have a whole bunch of other things on our plate as well. So that's a direction I would love to see in the future.
Thank you. We have a comment from Dr. Ewickman. Evidence is necessary, but not sufficient in the diffusion of innovation such as telemedicine for reproductive services. Terry Ann Thompson pointed this out. She noted that this particular service, while technically new, is still embedded in the milieu of our current healthcare system. This technology does not change the underlying culture and history within which it is introduced.
Absolutely. That's a great comment. And I agree with you wholeheartedly. I think, if I could add a few more places that I think we can or should see some other work in telemedicine. I mean, the first is to say that replication is key. And so we need more evaluation programs such as the one that was implemented by Dr. Stolberg and colleagues, so that we can see how this work functions in different settings, so we can confirm or extend the findings. I think that's really important. But I think what's also important is acknowledging what I said at the very beginning, which is that this is a nascent field. There isn't a lot of evidence at all on telehealth for contraception. And in fact, in 2017, the amount of services, the percent of telehealth for contraceptive services was less than 1% when they actually analyzed the claims, like insurance claims for telehealth for contraception. So while it is higher with COVID, right? Like it's dramatic, it's significantly higher. It is still not like 50% or 60 or 70% of how care is delivered. So there's a lot of work that is left to be done. I think the patient experience piece is huge. We need to know what people's preferences are for telehealth as a healthcare delivery model. We don't know that. We don't know what people's acceptability of telehealth for contraception provision is. And to Dr. Stolberg and colleagues' study, there is much to do and to learn as it relates to disparities in access to telehealth for contraception, right? Telehealth, when it was envisioned, was around bridging the gap and largely the geographic gap without thinking about much else. So there is a lot of work for us to do there. I also think we should be thinking about technology as it relates to self-education, right? And whether patients feel adequately prepared to make decisions about their contraceptive methods, or to self-monitor for contraindications, or whether they feel adequately supported as it relates to continuation of a method. So those are some studies that we should be doing, and we should be looking at the cost of telemedicine, right, for contraception delivery methods, and that includes hybrid models. You know, we talked about LARC and the fact that while there are some parts of the LARC experience that could be done by telecommunications technologies, a large portion of it still has to happen in person, right? So we should be looking at, or rather generating evidence on both hybrid models, this like in-person plus telehealth, in addition to, you know, fully, I think we're still figuring out what term we're using, but I guess low touch models where telehealth is in use. So there's a lot of work that I think that needs to be done, but the most important is replication at this point, to actually see whether the findings that we're seeing here can be confirmed and or extended in other settings. So that's what I will say.
Thank you. And by the way, this has been a really wonderful and rich discussion. I have, just to kind of sum up, if I can, I didn't know that only half of low-income households have access to broadband. And that's just a glaring structural disparity that came out of the conversations today. And people have commented on literacy, health literacy, cost, a number of cultural barriers and structural racism, and a lot of issues that we need to overcome in healthcare. And this is not telemedicine, it's medicine now. So it's a real opportunity. Really also how to make policies permanent that enable this to be paid for people, and how is CMS going to handle this in the future and work with states to do it. So I'd like to thank all of you very much for this outstanding and really timely and important work and your comments. I think we could just take a transcript and write a white paper from this conversation today, because I think there's a lot of really important points that I don't want to lose going in the future. So thank you very much. For questions, comments, concerns, or requests to present at a future seminar. Oh, could you advance the slide, Rachel? So my email is listed on the slide. If you could all take a minute for a brief survey regarding the presentation, I'd like to do evaluations, that would be really appreciated. And you'll be directed to a slide after you close out the window, and the link is in the chat box for the evaluations. Our seminar series, also, we will post a link to a video from this seminar on YouTube, where we have pre-existing seminars. And also, our seminar series will continue on Tuesday, April 20th at 3 o'clock with Dr. David Meltzer presenting his work on COVID-19 and vitamin D. And so thank you all again, and have a great rest of your week. Rachel, would you like to? Okay, you got the, okay, do you see the link in the chat box?
Yes, the link is there in the chat box.
Very good. All right. Any comments, closing remarks from anybody else? We have a couple minutes. Okay. Very good. Thank you, everybody. And thank you, participants, for logging in.
Thank you.
See you next
Thank you
time.
for having us.
It's our pleasure.